La presentación. Dando la bienvenida a todos ustedes a nombre de la Asociación Hispana de Profesionales de la Salud, hoy miércoles 1 de julio del año 2020, en su programa La Hora del Neurólogo, con el Dr. Williams y nuestros invitados para el día de hoy. Aquí tienen otros invitados que lo vamos a tener ya, el Dr. Carlos Williams, Amy Edmunds, que van a estar con nosotros compartiendo su experiencia con relación al tema de los accidentes cerebrovasculares en los jóvenes.
Ella no puede, espérate, ella no ha podido entrar porque no tiene la clave correcta. Yo se la he mandado los dos números que tengo.
Sorry. No sé, el número que yo tengo, déjame ver si...
834.
Sí.
640. 46. 531.
Sí, ese mismo es. No tengo otro, así fue que yo entré también y lo tengo en el celular también. Sí. Así que ya debe de entrar en cualquier momento. Quizá entró ahora y ya. Alguien entró.
Déjame ver.
Amy, are you there?
No.
No, todavía. Recordar, creo que Elsa tiene el teléfono abierto, Samuel también. Pongan su teléfono, su micrófono apagado para fines de captar buen sonido de la presentación y no tener interrupción. ¿Ok? Por ese lado. Sí, por eso el micrófono apagado, levantar la mano cuando tengan alguna pregunta y pueden usar el chat también para escribir en el caso de nuestra asociación, recordándole que acepta médicos, enfermeras, odontólogos, psicólogos, farmacéuticos, bioanalistas, procedentes de América Latina o de otros países, porque muchas veces nos llegan del África y de otros países que han estudiado en Santo Domingo o en Cuba o en Honduras o en diferentes lugares, pero son africanos, o sea, no necesariamente latinos. El próximo sábado vamos a tener este programa interesante, sábado 4 de julio, una fecha fácil de recordar porque es el Día de la Independencia Americana, a las 5 de la tarde, nuestro nuevo programa AHPSI al Día. Ese programa está dirigido a certificaciones cortas y ayudar a buscar trabajo y a crear bancos de trabajo. O sea que están invitados todos, pueden correr la voz si conocen algún médico, enfermera, psicólogo, laboratorista que le interese conocer más los programas directos. Ese programa de cada sábado está enfocado en eso, en ayudar a donde hay trabajo, donde tenemos certificaciones. Nuestra asociación ya está cumpliendo 31 años y lo que hace es ayudar a insertar a los profesionales de la salud en el sistema de salud de Estados Unidos. Y pueden ser miembros, ya lo mencioné, los médicos, enfermeras, psicólogos, laboratoristas, incluyendo asistentes médicos y estudiantes. Hemos tenido muchos miembros que siendo estudiantes se hacen miembros y cuando se gradúan pues ya pasan a otra categoría. Y el costo de la membresía es menor cuando es estudiante. Los valores de nuestra asociación siempre han estado ahí por 31 años, donde está la integridad, la honestidad, la colaboración, el respeto, la excelencia y sobre todo el servicio a la comunidad, que lo hemos logrado con un programa de Feria de la Salud que ya tiene más de 28 años de fundado, donde hemos organizado más de 175 ferias comunitarias de la salud con más de 175,000 pacientes atendidos. Estamos hablando de Nueva York, New Jersey, feria que muchas veces reúnen 1,000 pacientes, 2,000, 500 o 600, por eso hablamos de esa cantidad. Ofrecemos certificaciones cortas como asistentes médicos, asistentes de laboratorio, asistentes de farmacia, asistentes de dentista, en lo que van pasando sus exámenes. Esto es una buena forma y una manera rápida, corta de certificarse y conseguir trabajo. Ahora lo estamos haciendo online, poder ir llamando y comunicarse con nosotros. AHPSI al Día es el nuevo programa que ya comenzó la semana pasada. Nos fue muy bien, muy interesante, un gran esfuerzo que hace la doctora Carmen Rodríguez. Debe estar en la línea ya con nosotros, que ella es la secretaria, la encargada de educación de nuestra asociación AHPSI, Asociación Hispana de Profesionales de la Salud, incorporada en New York. Y ahí están todos los servicios que ofrece y la misión de ese nuevo programa, pero va a enfatizar en trabajo, un banco de trabajo y dar consejos de cómo obtener más fácil un trabajo en el área de la salud. Sí, este es el consejo directivo, que simplemente le quiero presentar los nombres: Leonor Tavares, la doctora Julia Bello, el doctor Carlos, que es el chairman, por mucho tiempo siempre colabora con nosotros, es fundador de nuestra asociación hace ya más de 30 años, junto con el doctor Elisel Guzmán, el doctor Bautista, el doctor Rodolfo Guzmán. Simplemente 4 cositas con relación a hacerse miembro. Si usted, ¿qué ofrecemos a nuestros miembros cuando firman y pagan su membresía? Bueno, lo primero es que te va a pertenecer a una institución de 30 años de servicio, va a recibir una identificación, un carnet, recomendaciones para trabajo, carta de recomendación también, y muchos servicios más que están en la página, que no nos vamos a detener en eso, simplemente comunicarse con nosotros. Usted lo único que necesita, si desea convertirse en miembro, para que corra la voz, una copia de su título, una foto digital y el pago solamente de $100 por el año completo. Hay 3 formas generales de pagar. Lo puede hacer con dirigido a nuestra cuenta de banco, el cheque, que es la cuenta del banco que nos pertenece. Puede pagarlo por PayPal, está en la página cómo hacerlo, o puede enviarlo por correo al P.O. Box que aparece en el link de la página. Puede llamarnos si tiene alguna pregunta sobre eso, o escribir ahí este correo a info@ahpsi.org para más detalles. Una cita final que quizá identifica a nuestra asociación, y es precisamente un gran humanista, José Martí, cuando dijo: hacer es la mejor manera de decir. Él pudo hacerlo, él lo hizo, y también aportó mucho, y todavía seguimos estudiando el poder y seguimos recurriendo a José Martí con sus grandes aportes a la humanidad. Así que básicamente eso es lo que tenemos. Vamos a pasar ahora a nuestros invitados. Doctor William, ¿pudo entrar Amy?
Bueno, estamos teniendo problemas con la tecnología otra vez. Ella tiene una presentación grandísima ahí y Verizon y no ha podido entrar.
No ha podido entrar con el Zoom, porque yo tengo la presentación, sí, podemos pasarla por aquí. Lo importante es que ella entre, y no puede entrar por el teléfono, por el audio, usando el celular, porque podemos
yo le
intentar
mandé
así.
la información.
No, que un número que ella puede llamar y poner el código, y así podemos quizá.
Ni el link ni nada está trabajando.
Pero todos han entrado por ahí a través del link.
Restituyo, el link no está trabajando. Ni el teléfono, ni el Zoom, ni el código de Zoom. All right, so hold on one second.
Déjeme ver si podemos poner si yo le puedo darle un número de teléfono que ella pueda llamar.
¿Tú tienes el teléfono de ella para que la llame?
Yo le voy a enviar de un teléfono que ya puedo entrar por un audio, por el audio.
Mándaselo. Yo no sé nada.
Sí, déjame ver si encuentro aquí. ¿Alguien entró, Sabari? ¿Alguien conté? ¿Será ella?
No, este es Teodulo Davis.
Ah, Teodulo Davis, ok. Sí.
Hold on. Tengo que cerrar para poder subir mi presentación, ¿ok? Momento.
Ok, perfecto. Doctora Carmen Rodríguez, ¿está en la línea?
Sí, aquí estoy. ¿Me
Ah, ok.
escuchan?
Sí, adelante.
Buenas noches a todos.
Una bienvenida de parte suya. Sí. Nuestra conferencista no ha podido entrar. Déjeme ver, Carmen, pero el problema es que yo no puedo salirme de la presentación para buscar los teléfonos, que no los tengo a mano, para que ella pueda, si tiene alguna forma. Déjeme ver, a ver si lo puedo hacer. Doctora Rodríguez, ¿puede decir el programa del sábado para los que estén interesados en participar el sábado a las 5 de la tarde con nuestros invitados?
Sí, por supuesto. Le estamos invitando para que todos los sábados se unan a nosotros este próximo sábado, día 4 de julio a las 5 de la tarde. Es nuestro segundo programa y hemos iniciado estratégicamente dándole informaciones a los miembros y a los que quieren pertenecer a la institución, pues dándole pautas sobre cómo obtener empleo y la mejor manera de obtenerlo de la manera menos traumática y más eficiente, cómo avanzar todos en su carrera. El sábado pasado iniciamos con una maestra de maestros, como yo digo, y ya nos habló sobre el uso de la tecnología en la búsqueda de empleo. Clarisa Abreu, precisamente. Sí. Y el próximo sábado, Josie, el apellido se me va de la mente. Josie Mato compartirá conmigo. Vamos a hablar sobre las certificaciones que ofrece la AHPSI. Entonces hablaremos y le daremos orientación a toda persona que tenga preguntas, que quiera enviárnoslas antes y para tenerlas ya listas, puede enviarlas. Pueden también participar de manera activa haciendo preguntas por el chat y que inviten a todo el que conozca, porque precisamente el sábado pasado yo invité a una ingeniera industrial que está en Michigan haciendo un PhD y ella dice, yo no sabía nada de eso. Yo tengo que conectarme con la profesora Abreu porque no sabía todo lo que yo tengo que hacer. Y está, o sea que todos nos beneficiamos. Entonces, por favor, rieguen la voz de AHPSI tu voz.
Sí, exactamente. Sí, así es. Vamos a estar ahí los sábados.
Restituyo.
Sí, adelante.
Hi. All right, so we're going to do this. How you doing? I'm sorry about the technology.
Okay,
we're going to do the slides, and Amy's going to speak over the slides from here, from my telephone. I'm going to put it on a speaker, okay?
Okay.
So you have the slides. You could present them.
Okay. Let me put. Déjame buscarlo. Yo lo tengo por aquí.
So he's loading up your presentation, and I'm going to put you on a speaker in a minute. Unfortunately, I don't know about the issue with the technology thing. I'm not a technologist, so I cannot tell you. I'm sorry. So, here goes, Amy. You could start talking.
La estoy buscando. Un segundito. Déjeme ver cómo yo...
No, ella puede comenzar a hablar sobre la presentación de ella.
¿Y ella la tiene? ¿La puede presentar?
No. Tú la buscas, ella va a comenzar a hablar sobre la importancia del accidente vascular en los jóvenes.
Okay.
All right, Amy? Could you hear me? Could you hear me?
Yes.
Okay. Go ahead. You're gonna start discussing why are we trying to talk about young people with a stroke. Could you tell us the relevance of that subject?
Would you repeat your question?
Yeah. Could you tell us why it's important to talk about young people with a stroke?
Okay. It's very important to talk about stroke in young adults because we are actually, there's an increasing prevalence of this population, and it has been going on now for more than 20 years, and this is a global phenomenon, and I'm especially excited to be speaking with you and your audience this evening because minorities, particularly Hispanics and African Americans, have a disproportionate rate of stroke among young adults.
So, Amy, no sé si hay alguien que necesite traducción o si no hay alguien, continuamos en inglés. ¿Hay alguien que necesita entender lo que está pasando? No, nadie puede decir nada. Ok, restituyo.
Sí, adelante.
¿Tengo que traducirlo o no?
No, tú puedes hacer un resumen como tú quieras, como tú consideres.
Ella nos está diciendo que, que Amy Edmunds is in the thing. Restituyo, open the microphone for Amy Edmunds. She's in there.
Sí, sí, la estoy buscando para abrir la presentación.
No, mira, debajo de tu nombre. Oh, okay. Cierra lo que no hay nada, cierra lo que no hay nada. No hay conversación. Cierra, restituye, por favor.
¿Perdón?
Cierra lo que no hay conversación. Cierra este micrófono.
¿Qué micrófono?
Amy.
Yes. She's there.
Okay. Amy, you tried to connect your microphone, but it wasn't working.
Okay.
All right, now you're in. Now you're in. Go ahead. Could you hear me? No. Okay.
No te oye. Amy.
No, ya. Qué desgracia. Okay, it's back. Hello.
Sí. No.
Hello.
No te oye.
Porque el micrófono está cerrado, yo creo. Hello, Amy.
Yes.
Sí, estás.
Okay.
Sí.
We're here. So keep talking about the young stroke.
Okay. Do you want me to share my screen?
Yes, could you?
I think I'm in.
Okay, I think you are because I see your name here.
Yes.
Restituyo, let her share her screen.
Ok. Ok. Sí, ella puede poner, ella está en la computadora.
Sí.
Sí.
El nombre está ahí. Amy Edmunds.
Ya ella puede ponerla. Si la tiene la
Share your
presentación.
screen, Amy. You could share your screen. You could share your screen now.
Do you see?
Restituyo, ¿lo puede ver?
It's coming. Let
Do
me
you see the slides?
Yes.
Not yet.
No yet. Hold on.
Let me.
Ábresela.
Está abierto. Ella puede hacerlo. Ya puede entrar.
Amy, you keep going. Keep going. He said he could see it.
Sí, sí.
He can see it?
Yeah.
Okay, great. Okay. All right. So, hello, everyone. It's a pleasure to be with you tonight. And I'm going to discuss stroke in young adults. And I'd like to make two primary points tonight. The first is to discuss current issues and trends regarding stroke in young adults. And then secondly, I'm going to discuss some of the unmet needs that are impediments to our survivorship.
William, tú tienes tu presentación, no la de ella, no se ve nada.
Oh, espérate, déjame sacar la mía.
Hold on, Amy. Dr. Williams had to. Okay.
Okay. ¿Y ahora?
No yet.
¿Todavía se ve la mía?
Sí, ya se fue.
Okay. All right, you could go. Keep talking.
Okay. So we're going to get started by examining first the current trends. And so, as I mentioned, there is an increasing growing prevalence of stroke among young adults. More than 31% of all strokes occur among those under the age of 65. What's interesting is that despite this line prevalence, we do not yet have a global standardization for a definition of stroke in young adults. So for the purposes of my organization, we define stroke, young stroke, as being a first-time event that occurs between the ages of 18 to 65. And the rationale behind that particular definition was to first distinguish stroke in young adults from pediatric stroke. And so we're using 18 as a marker there. And then 65 is the other endpoint because over 65, particularly in the United States, that is the age of entitlement for federal benefits that are not previously made available to assist with rehabilitation and recovery needs. This definition was further endorsed by Bo Norving, the winner of the 2015 Karlensko Award. He's also the past president of the World Stroke Organization, and he addressed our conference back in 2015. And he defined the difference between geriatric stroke and stroke in young adults as thinking of the different endpoints along the walk of life. Bo Norving's primary point was that a geriatric stroke happens towards the end of life, and a young stroke occurs early within the lifespan, and that survivor is looking at lifelong disability, as opposed to that end of life spectrum where the disability may only last for, say, 7 to 10 years.
Mm-hmm.
When a stroke happens among a young adult, this is a time of high complexity in that person's life. Many times they are right in the midst of completing their higher education, they're raising families, they're just getting a start in their career, and they may or may not have even begun any significant savings or any retirement planning at that point. Back last year in 2019, I had the pleasure of being at the European Academy of Neurology conference, and one of the speakers there, Renita Sarwinski, made the point that there were worldwide more than 2 million young stroke patients, and notice her definition of young stroke was the ages 18 to 49. And essentially her point was that every 10th stroke patient is in fact a young stroke survivor. She also went on to acknowledge that in recent years there's been a real paradigm shift in recognition of stroke in young adults as an acute disease that's occurring during a vulnerable period in life with lifelong consequences on virtually every aspect of life. And so that's a reinforcement for the previous slide that I shared with you. Now, looking specifically here in the United States, stroke in young adults occurs 1 out of every 5. And this is a statistic taken from the American Heart Association, and they were looking at strokes between the ages of 20 to 55. So we're averaging about 1 out of every 5 as being a young stroke in America. What's interesting too around this discussion with stroke in young adults is that we don't have a clear understanding of causation or even in recognizing symptoms. And so Walter Koroshetz, who is the director of the NIH National Institute for Neurological Disease and Stroke, he spoke at our conference in 2016, and one of his concerns is that the FAST acronym does not acknowledge severe headaches as being a sign or symptom of stroke. And this is particularly significant for stroke in young adults because so many of them do in fact present with headache as being one of the primary symptoms. So there's an opportunity for us certainly to message the public that severe headache is also a sign of stroke. And this is actually an ad that was created by NINDS to help emphasize that point. Now, this year has been particularly interesting for new studies that specifically address the Hispanic population. And so you may be aware that in January, from the University of Cincinnati Neuroscience Research, there was a study that was released showing that young Black and Hispanics are less likely than whites to be disabled or die from hemorrhagic stroke, and this would be 3 months out. And so the takeaway was, compared with white patients, Hispanic patients had a 66% lower risk of poorer outcomes. And so that was very interesting, and that just happened this year. Also this year, and this, the North Manhattan study was presented at the ISC this year in Los Angeles, and this was a study that highlighted that Blacks and Hispanics of Caribbean descent may have a higher risk of stroke than whites. And what was significant about this is that it's actually the first study to document this risk. And so in a comparison with whites, the North Manhattan study is showing that Hispanics had a 50% higher risk of stroke. Also, building on causation among young adults who experience stroke, many of the factors that young stroke survivors experience are not likely preventable. So, for example, this is a diagram that was created by Jukka Patula from Finland, and he shows a number of these here, and so I'm not going to go through and read this to you, but certainly you can appreciate the frustration of young stroke survivors who are told quite often that their strokes are cryptogenic. That certainly aligns with my own personal experience as a stroke survivor. So when someone tells you that your stroke is cryptogenic, what is it that you're supposed to improve exactly? So, for example, at the time of my stroke, I was running 5K races. I've always eaten a healthy diet, and my blood pressure on the day of my stroke was 110/70. So what is it that I'm supposed to improve? And this is certainly, it highlights, the need for more research in this area, because we don't know why this is occurring. And so this is certainly similar for survivors who have an aneurysm or you have a dissection, those are causes that are not likely preventable. How is someone going to prevent having a dissection? How do you, how do you do that? So we need to be, very mindful that causation in young adults can mimic geriatrics, geriatric patients, but there are also significant differences. A priority among stroke in young adults is being able to return to work. And so at the same conference in Oslo, there was a presentation that really emphasized that returning to work is only a realistic option under optimized conditions. And those optimized conditions would be that the survivor is able to work less than 48 hours a week, that they're not to be working night shifts, that they're sleeping more than 6 hours a night, and that the supervisors and colleagues are there to support and to help them, sustain their performance. And so some of the adjustments that need to be taken in consideration are shown here. And so that would be impaired cognition, the stigma of the survivor, their impaired resilience, pain, functional impairment, epilepsy or seizure control. Is that person going to be able to drive? Can they maintain their driver's license? They may have reduced social status, and it may even result in them having less income. They may or may not be able to return to their old position. And so for many, particularly younger stroke survivors, returning to work is like the gold standard, that they have actually been successful in their recovery. And this is a major distinction between a geriatric patient who many times are already at the end of their working life or at the end of their career. And so these considerations are no longer meaningful for geriatric patients. From Canada, there has been a great deal of research done specifically on the rehabilitation of younger stroke patients, and Robert Tisle is one of the leaders from the Canadian medical community. And so some of the highlights that they have addressed is that vocational issues are often neglected, and that we really should think about rehabilitation for young adults as being age and stage related. And so in terms of mortality with young stroke patients, it is generally found that there is a higher rate of mortality for the next 10 to 20 years, much more than our peers who do not have a history of stroke. And then this is Jukka Patula. We saw his chart earlier, and Jukka goes a little further with his research in Helsinki and says that after 5 years, 1 in 10 young stroke survivors die prematurely. 21% of them died because of a secondary stroke. 31% died due to cardiovascular disease. The third reference there is an error. So sorry.
That's okay.
Okay, and so now I'm going to shift gears, and we're going to talk about some of the unmet needs of young stroke survivors. And so unmet needs regarding survivorship. And for young adults, survivorship starts at the moment of discharge. Once we are released from the hospital, we put on our survivor hat. And being a young stroke survivor, you are grateful that you survived the stroke, but then survivorship has its own minefield for us to navigate. And so as an example, I'm referencing a young woman, Jamie Hancock, who is in California. Jamie had a stroke at the age of 31, and she had 2 young children. And what her recovery involved also having to go through rehab for opioid addiction that were prescribed to her by her primary care physician, who was unequipped to help her manage her post-stroke pain. And so in addition to the stroke recovery, I've listed here some of the issues that Jamie also had to overcome. She had cognitive deficits. Her family was dealing with the personality change that was also a consequence of the stroke, the post-stroke pain. Her entire family was very fortunate that they could afford to go to family counseling during this time. And then as a young mother, Jamie herself formed a support group of other women who had experienced stroke and were trying to parent their children. And so this is just a snapshot of the complexity of what a young stroke survivor is having to navigate that is very distinctive from the experience of a geriatric stroke patient. Also out of Canada, one of the acknowledgments of the work of Robert Tisel is that there are psychosocial and supportive needs that should be prioritized among young stroke survivors much more than just the physical deficits that are often a consequence. Sometimes during recovery, there's more of an emphasis on does the person need physical therapy or speech therapy or occupational therapy? And yes, those things are needed, but we also have a very strong need for the psychosocial and the other opportunities to have peer support and to be united with other people who are having a similar experience. And that is not the same as going to a hospital-based support group and being the youngest person in the room and all of the other survivors are 70 or 80 years old. That's not the type of bonding that we desire. So, re-emphasizing that point, we need to be connected with support organization and with those who share similar experiences. And so there is a tremendous need for there to be more CME education, particularly about late onset deficits. So going back to the example of Jamie Hancock, her primary care physician did not have appropriate education to help him to better meet her needs. And so there's a tremendous opportunity for us to do a better job of educating primary care physicians to assist us. And at this time, most stroke survivors are pushed down for follow-up care to primary care physicians. And so there's an opportunity for some of that to be reexamined as well, and that's an opportunity for the new ICD-11 that will be coming forward, and hopefully some of that will provide a re-engagement opportunity for neurologists to renew their interest in also serving stroke patients on a much broader scale. Another example of an opportunity would be related to late onset deficits is untreated spasticity. When a young stroke survivor has untreated spasticity, it's particularly horrific because going back to the reference of Bo Norby, younger stroke survivors are having the period of disability extended over their lifespan. You could be a 30 years old young stroke survivor and potentially live for another 30 years. You could live as long post-stroke as you have lived prior to your stroke. And so to imagine having spasticity, for 20 years is pretty horrific. And so we need to be able to recognize these types of deficits, early on. And spasticity is not something that's going to be manifest, at the time of discharge from the hospital. And, the point that I'm making is that we haven't done a good job of educating our primary care physicians, some of whom may or may not have even had a rotation in neurology, to know what to look for, or how do you distinguish spasticity from arthritis or bursitis or some other condition. I wanted to also touch upon there is a lot of attention being given to transitional models of care, and young stroke survivors are particularly prone to be eligible for transitional models under the early supported discharge. And so one that I'm highlighting here is the COMPASS program out of Wake Forest in North Carolina, but globally there have been several transitional care programs. TACUS is another one that was presented at ISC just this past year. And so this is a trend that could potentially be very beneficial for not just young stroke survivors, but all stroke survivors. But the burden of a early supported discharge program is that so much is contingent upon the resources of the local community. And so if a survivor is in an underserved rural community, for example, having a transitional care program is pretty meaningless, because there's so few services that would be accessible to them in the community to be a resource. Another opportunity that we have for stroke survivors, and again, this is not unique to only young stroke survivors, is for annual assessments. It was a point of outrage for me as a stroke survivor to discover that annual assessments are not routinely performed. And so if we are to evaluate stroke patients, but we never measure or evaluate improvement from year to year, how do we know if they're progressing or if they're even regressing? And so, and this is particularly mind-boggling because there are post-stroke checklists. There was one that was developed by the World Stroke Organization back in 2012, and it's an 11-point checklist. This is available online for download, and it's available in a number of languages. And it has been used appropriately in many other countries. We just haven't done a really great job of publicizing its use here in the United States. And so of these 11 points, I personally like to distribute this checklist for caregivers and survivors to use on their own, to be able to communicate effectively with their primary care physicians about their progress. And we suggest that they do this on the anniversary date of their strokes. This tool was actually developed for providers for them to evaluate their stroke patients in a much more uniform way. One of the positive aspects of sharing this with the caregivers and survivors is that it helps to educate them on key points that they should be monitoring their own behavior for throughout their recovery. We also have an opportunity to empower caregivers, and using the checklist is a way to empower caregivers. And when we educate the caregivers of the survivors, we actually are also helping to reduce hospital readmissions. And so this would be a win-win. Last year, I had the opportunity to travel to Dubai, and I was visiting a stroke unit there. And one of the points that I was most impressed with was the way that here I am in this, what we would call an undeveloped, country with a stroke unit, and they were actually hosting a caregiver workshop where it was like a cattle call. They invited once a month, they brought and invited the caregivers to come to the hospital for a training. Imagine training caregivers. We could so benefit, the survivors would benefit, our hospitals would benefit if we would think of ways to engage with caregivers to help them do a better job, to help them to help us. And so there's an opportunity to think about that caregiving relationship very differently. And so another point with caregivers is, and this is a particularly interesting dynamic, when you are a young stroke survivor, it's quite possible that as a young adult, 30, 40 years old, you could be, you could quite possibly be cared for by an elderly parent. And so it's really important that we also examine ways to evaluate caregivers. Is the caregiver capable of giving care? And so there are also models for checklists for this type of assessment that are readily available as well. And so part of the last point that I want to make with you is that we really need to have a call to action among researchers to engage young stroke patients in research projects design, data collection, and the interpretation of results. And so this here is a model of work that I've been engaged in personally with the University of South Carolina, and we provided, the Young Stroke Organization provided a focus group of young stroke survivors, and we created an assessment tool to measure the young stroke experience. And so this is an example of how I'm saying let's work together to try to resolve some of these outstanding issues. A new research question that I'm trying to get people involved in is the question of aging. We have not collected data on the young stroke experience. And so now we have young stroke survivors who are aging, and we have no points of reference as to how to manage their care. And so Carol Keegan is an example. She's now 73. She had a stroke at 22, and she is having issues in her recovery or in her rehabilitation, and we have no data points to help direct her care. Okay. There's also, I wanted to bring to your attention a request for information from NINDS with a deadline of July 15th, where there is a request for all types of stakeholders to share their experience. The NIH is interested in documenting particularly disparities in health. And so this is a tremendous opportunity for those of you on the call today to step up and share some of the disparities that the Hispanic community may be experiencing. I also had previously referenced the ICD-11 is going to be coming out in January of 2022, and we are hopeful that the reclassification will help to redirect some of the focus and the interest on stroke in young adults. And then in closing, I'd like to encourage you to share this message to all of your stroke patients, and particularly among survivors, young stroke survivors, those of us who are fortunate enough to reintegrate back into the community. Sometimes we are feeling invincible, and we think that, you know, we have moved forward, but we may need to be reminded that we are, in fact, in a high-risk group for COVID-19, and that we are very likely at a higher risk for a bad outcome or even death, and that it is imperative for us to follow guidelines for social distancing, wearing masks, and for hygiene. So thank you so much for your time today, and I would be happy to address any questions in the short time that we have left.
Yeah,
Okay.
Amy,
Thank you.
it's incredible the ability you have to maintain this conversation going. You've been doing this for quite some time, and we are very happy and very privileged to have you tonight talking to us about a topic that for me and you seems to be the main reason for our existence, because you have dedicated your life to talk about young stroke. I have worked in stroke for so many years that I don't know how many, and we continue to have the battle uphill, trying to make people understand that this is a serious problem, that it doesn't have an age discrimination, that it doesn't have a sex or race discrimination, but it goes around across the board to everybody.
That's right.
And like you mentioned, the Hispanic, the blacks, the white, the yellows, the pink, and everybody has the same opportunity. Unfortunately, genetics and environmental factors determine who will be the next victim, but we cannot predict that at this point. And like you said, we have no path to determine, which risk factors will be treatable or correctable in the situation of a young person when that person has not come to the attention of the medical system because they did not have medical problems prior to this episode. Many times they come to our attention just because of the symptoms. And like you mentioned, the symptoms could be neglected or ignored or being so vague that nobody recognizes them as a major problem.
Right, and because you are young, so we still, I'm still floored every day to hear cases of young people showing up in the ER and having to come back twice.
Exactly.
Because people assume because of their age they couldn't possibly be experiencing a stroke.
So they get discharged home, they have to come back because the situation has not improved, and now we have a disaster in our hands. So I wanted to ask you permission because I want to switch language just for the comfort of some of the in the audience. To see if they have any questions or whether they have anything that we need to address in particular. Hold on one second, don't hang up yet, Amy. So, restituyo, si alguien tiene alguna pregunta o algo que quiera discutir y si no entendieron lo que se refirió, yo sé que fue difícil desde el punto de vista técnico lo que hicimos, pero ustedes no saben el privilegio que es tener a Amy, porque Amy es una persona muy ocupada que trabaja a niveles muy altos en esta situación. Y nosotros, a través de las relaciones que tenemos, hemos podido conseguir que ella nos dedique una hora de su tiempo. Ella lo ha hecho gratuitamente y de todo corazón. Y la institución tiene que reconocer que Amy nos está haciendo un gran favor. Y las personas en la audiencia, ojalá que hayan podido sacar algún provecho de esto porque lo pueden compartir con cualquier persona. Puede pasarle a cualquiera, una persona de 20 años. Yo he tenido pacientes con accidentes cerebrovasculares de 15 años de edad. O sea que no importa la edad de una persona, cualquiera puede tener un accidente cerebrovascular. Y recuérdense que la gente que tiene sickle cell anemia, anemia falciforme, también tiene más riesgo de tener accidentes cerebrovasculares a cualquier edad. ¿Alguna pregunta?
Vamos a ver si alguien tiene alguna pregunta.
Hold on, Amy. I'm asking for any questions.
Doctor Williams, pueden enfocar. Doctor Williams, ¿puede enfocar un poco el consumo de droga en jóvenes y la crisis del opio y todo eso?
Sí. Amy, somebody is concerned about the use of substance abuse and stimulants and sympathetic mimetics like cocaine or all of those things, including now chronic use of marijuana as a reason or as an impact of how does that interact with the young stroke patient?
Was a study that was done out of Wayne State in Detroit several years ago that did address the issue of substance abuse with stroke, and certainly just because of that population, the inner city urban geography of the study that was based in Detroit, I believe that the primary drug that was encountered there was cocaine. But I would caution in a broad generalization of substance abuse. That is not the primary driver for the increasing prevalence of stroke in young people. It is not an overwhelming percentage of the population using illicit drugs. I caution you to reflect on the slide that I showed from Juka Patula, who listed many of the other points of causation for stroke.
So, en resumen, hay una condición, el hecho de que, por ejemplo, cocaína, que es una de las drogas más populares, la marihuana, uso crónico, y la gente joven usando estas sustancias, todavía no está claro si eso tiene algo que ver con el aumento de los accidentes cerebrovasculares en las personas jóvenes. Sin embargo, personas jóvenes que tengan predisposición a presión alta, a diabetes o a problemas cardíacos o enfermedades cardíacas o enfermedades sanguíneas tienen mucho mayor riesgo. Obviously, sería ideal que una persona no se pusiera esas cosas, pero el que lo elige y lo hace tiene que saber que sus riesgos son mayores y las condiciones y las consecuencias de la accidente vascular son peores.
Okay.
¿Alguna otra cosa?
Sí, la doctora Carmen Rodríguez, Dr. Carmen Rodríguez, has a question too.
Sí.
Doctor.
Buenas noches, Amy. Gracias por su participación. Y como rehabilitadora
Háblale en inglés.
Okay, like a rehabilitation physician, I am so happy that you mentioned the importance about the rehabilitation in the young people. I have a lot of experience, unfortunately, see that cases in my life, but with a good multidisciplinary team, you can find excellent results. Thank you for mentioning it.
Okay. Yeah. Dr. Rodriguez is a rehabilitation physician, and she's working and has used the tools that you mentioned in treating young patients and assessing the condition of young patients after a stroke. And she wants to thank you for everything that you have told us tonight.
Otra doctora está en la línea.
That's great.
So at least one of us knew about you before.
Great.
Alguien más levantó la mano, sí, la doctora, no tengo el nombre, solamente dice doctora. Doctora, que levantó la mano, adelante.
Yes, hello Amy, this is Karen. First of all, thank you so much for the information, all the wonderful information that you gave us tonight. I would like to know if you have some information or if the pharmacologic treatment with this young patient, it is the same as an older patient, or we have different rules to treat these patients.
You got that?
I lost part of what was it that she was comparing with the older patient?
Yeah, the pain, the treatment of the pain. The younger and the older. Yeah. Yes.
I really am reluctant to comment on the levels of pain. I don't have a comparison, you know, to really speak to that. I have only, you know, the firsthand accounts of what some of the survivors, you know, have shared with me, and I know that it can be very debilitating.
Yeah. So, lamentablemente ella no tiene una respuesta concreta, pero tiene la impresión y ha tenido anécdotas de que los jóvenes tienen un nivel de dolor que puede ser deshabilitante para ellos después de un accidente cerebrovascular.
Okay. Thank you so much. It's good information. I think I couldn't explain to me correctly. What I was trying to ask is if we have different pharmacologic treatment for early young patient than elderly patient.
With pain or without pain, or are you talking about stroke itself?
Yes, just the treatment.
For the stroke itself?
Yes.
Okay. That, I can tell you that there is not. What we do as a neurologist is to try to figure out the reason for the stroke and then address the risk and the reason for the stroke. When you find a vascular malformation, you're going to try to correct that if correctable. If you find a cardiac malformation, you're going to correct that if correctable. If you find a condition like a disease, like a blood disease or a pathology that could be managed, you're going to do that and manage it for the long term. The goal of the treatment is to prevent the person from having a second event, the next event. And that could entail the whole life of the person. In some cases, like in my most recent young person here, she did have a stroke. She's in the late 40s, mid 40s, and we found that she had a small PFO, patente, foramen ovale patente, y se le corrigió, y ahora ya está, lo único que le queda es un poquito de pérdida de sensación, pero no tiene déficit físico. O sea que cada caso tiene que ser evaluado independientemente.
Okay. Gracias, doctor. Muy amable.
No hay problema.
Thank you, Amy.
Amy, thank you.
Thank you. Anything
Ese
else?
tuyo también.
¿Alguien más? ¿Alguien más tiene alguna pregunta? Puede hablar. Puede abrir el micrófono. If somebody has more questions. Anything else?
So,
Yo,
Amy,
hi.
Sure. Adelante.
¿hay alguien más?
Yeah, which is the
Sí.
most concern about the lifestyle in younger people and the impact in CVA and stroke?
The lifestyle, after or
Yeah.
before the stroke?
Before stroke.
Uh-huh. Amy, lifestyle is before the stroke in the young person.
I'm not understanding the first part.
The lifestyle, you know, how does that
Which is
affect?
the most concern about the lifestyle in
What
younger
is the most concerning issues about lifestyle of young people before a stroke? What things would you address the most?
This is the question around lifestyle is it's one of the most concerning issues because myself, for example, before my stroke, I had shared that I was running 5K races. I was eating a healthy diet, and my blood pressure on the day of the stroke was 110/70. And so what is it as a cryptogenic stroke survivor, stroke of unknown cause, what is it about my lifestyle that you would have had me to do differently? So I'm very reluctant for there to be a broad generalization that young stroke survivors need to alter their lifestyle in some way.
So,
Or in some way that's more obvious than a geriatric patient.
yeah.
activity.
So, lo que pasa es que, once more, la respuesta es la siguiente. Cada quien tiene que ser analizado independientemente, porque en el caso de ella, por ejemplo, cuando ella tuvo su accidente cerebrovascular, ella era una persona sana que no tenía ningún problema con utilización de drogas, corría 5 millas al día, hacía ejercicio, tenía una presión normal y no tenía problema con el ritmo cardíaco, no tenía ningún riesgo conocido y por lo tanto no puede hacerse una generalización de las cosas que debe hacer una persona para prevenir stroke. Tiene que ser
Maybe
individualmente.
inactivity.
Inactivity as a whole is bad for everybody. That's a factor, yes. But for somebody who's running 5 miles a day, it's not a problem. So, however, either the person with inactivity or the person running 5 miles a day in young age, both of them could have a stroke regardless. So that's the problem with that situation, is that inactivity could be a factor for somebody else's, but then activity is not the reason for the stroke and somebody else's may be active. That's why you need to take each patient case individually to analyze it and determine what things could be done. All right.
Okay.
I don't know if anything else, Restituyo.
¿Alguien más?
Okay, thank you.
No, creo que no. ¿Alguien más? Thank you, Rosana. Thank you, Amy. ¿Algo más?
No, vamos a terminar.
No veo más nadie. Yo creo que estamos bien ahí. Dr. Williams and Amy, thank you very much.
Amy, thank you so much. Thank you so much for your wonderful presentation. Very good.
Thank you.
So, That was the
Okay,
part of the participants that were thanking you on behalf of themselves and us, both because of your dedication and your time to share with us. We appreciate it and understand that you have better things to do in the afternoon on a Wednesday, but you choose you chose to share time with us, and we greatly appreciate that from you, Amy. Thank you, Amy.
Okay, thank you so much.
Have a good
Bye-bye.
night and say hello to Mama.
Have a good
I
night.
will. Bye.
Good night. Thank you.
Bye bye.
Gracias a todos. Bye bye, doctor. Gracias, doctor William.
Gracias a todos.
Doctor.